Hello, my name is Ruben Mesa, one of the hematologists at the Mayo Clinic in Scottsdale, Arizona, and I'm pleased to be joined today by my expert colleagues in myeloproliferative neoplasms, Dr. Serge Verstavchik from MD Anderson Cancer Center and Dr. Stephen O from Washington University. Today we're focusing on expert perspectives to have a discussion regarding a symposium we had today at the U.S. Focus on Myeloproliferative Neoplasms and myelodysplastic syndromes. And specifically, the focus of this meeting was around JAK inhibitors and their impact on myeloproliferative neoplasms, particularly in this era of targeted therapy. Now, today we tried to focus on a range of topics related to how JAK inhibitors are having an impact on MPNs, and specifically dividing it up by each of the diseases: essential thrombocythemia, polycythemia vera, and I myself had a focus on myelofibrosis, long a known target of JAK inhibitors, but how we're viewing those therapies in particular in relation to patients who have underlying cytopenias. But perhaps to begin with first, I'll ask my colleague Dr. Verstavchik to give us a high level, perhaps a few key takeaway points that are relevant to your practice about JAK inhibitors and polycythemia vera.
Thank you, Ruben. As we know, JAK inhibitors are very active medications for polycythemia vera. Underlying biological abnormality in all types of myeloproliferative neoplasms is a hyperactive JAK-STAT pathway, and that happens due to several different mutations, of which JAK2V617F is the most common, the one that we all know about. That was the first one discovered in 2005. That led to a development of JAK inhibitors. So in polycythemia vera, about 95% of the patients have that mutation, and few other percentage of patients have a JAK2 exon 12 mutations, and then there is a link mutation that can also activate the JAK-STAT pathway. And these mutations, which we like to call driver mutations, activate the JAK-STAT pathway. So the goal of the therapy in all the MPNs, and particularly in PV, is this hyperactive JAK-STAT pathway. And ruxolitinib was the first medication tested and approved for therapy of patients with polycythemia vera, and particularly for patients that do not do well on hydroxyurea. That means the hydroxyurea intolerant or resistant patients. And as we go through this process of identifying these patients and developing new drugs in PV, to me it's fascinating where we started and where we ended. First, of course, the diagnostic process of the polycythemia vera has been improved, and now in April of this year we in fact had a new publication of modified ways to identify PV. There are two aspects that are very important here to understand, and first is the significance actually of a bone marrow biopsy that was brought up from being a minor criteria in prior editions of WHO classification to a front to be a major component of the diagnostic process. And the second is realizing that some patients with polycythemia vera may not have very high red blood cell count that we used to see classically in PV patients. They may have already iron deficiency that would lead to perhaps lower levels of red blood cell count, and some ET patients with borderline hematocrit or hemoglobin in fact do have a PV. So lowering the threshold for red blood cell count, bringing up the significance of bone marrow biopsy, led to a modification of a diagnostic process for PV. This is number one. The second is our ability to really understand fully the benefit of therapies when they are needed. Of course, one first thing need to identify a patient in need of therapy, which is being improved by our prognostication models. But once you start a therapy, and the first therapy usually in United States is hydroxyurea, when we talk about cytoreductive therapy, and that is needed on top of phlebotomy and aspirin to decrease further the risk of thrombosis. That's what we are talking about. So our ability to understand fully the benefits of therapies in general in PV has broadened from looking only at the red blood cell count. And we did certainly confirm in 2013 that hematocrit below 45% is the valid target, because that would decrease the cardiovascular events and mortality that goes with that. But now we are talking about normalizing the white cells, normalizing the platelets, improving the quality of life, as well as eliminating weak spleen if it's present in these people. So total 5 factors, right? There's 3 lines in CBC, symptoms and a spleen, and with that we can perhaps better understand the potential of medications to help the patients and identify patients that do not do well. Because we are talking about the quality of life of patients and the long-term outcome of the patients in all aspects as a person, rather than just looking at a red blood cell count as a target for therapy. And with that a realization of the potential of helping patients at multiple levels, we now know that maybe 10 to 20, maybe even up to 25% of the patients don't actually do well or satisfactory to therapy with hydroxyurea. And in that area, we have a role for JAK inhibitors. This is exactly where the JAK inhibitor ruxolitinib was approved not too long ago to help manage those patients, because after hydroxyurea, we really don't have too many options. One can go to interferon. That may work in some patients, but in many it does cause some side effects. As we know, it's injectable. Even with the new preparations that are long-acting interferon, so-called, people cannot tolerate it forever. Median experience so far says that median exposure to interferons is about 5 years, and we are talking about a need for therapy that will work over decades. So other alkylating agents or other therapeutic approaches in the second-line polycythemia vera did not really exist or were harmful to patients. So I welcome the development of the JAK inhibitor in a second-line setting. And here we again need to understand, by looking at all these 5 factors, the CBC, 3 lines, the spleen and symptoms, the potential of a JAK inhibitor to help patients in second line. That's the focus where I see further improvements in ability to identify patients needing to change from the front line to the second line, understanding the benefits of the second line therapy. What is that that will lead one to treat patients long term with the JAK inhibitors? When do they fail? What do we do next? This is the area of a certain degree of uncertainty, in fact, to understand full potential of a new medication on the market at the moment.
So perhaps if I might ask, in your experience, since ruxolitinib has been approved as second line in patients with P. vera, have you found other scenarios where you might consider it outside of the second line, earlier perhaps, or what is your threshold for kind of failing hydroxyurea? In some patients, do you wait longer compared to others?
I think this is really a very important practical question. Nothing really obviously is a black and white. It's not that you can fully implement definitions that we have in place in everyday practice for every single patient. There are different aspects of the disease, patterns that led you to think outside the box and say, hey, I have a patient on hydroxyurea, for example. Patient has good control of the blood cell count, but still has terrible symptoms. Are symptoms that patient has a good reason to change. And in the past, one would not even pay attention to a quality of life to that extent that we do now when we look at the person as a whole. And that would perhaps lead us to earlier intervention with hydroxyurea. The second question, for example, is in the young people who do have thromboembolic events. If we use the hydroxyurea, we may actually increase the risk of later on side effects like a skin cancer. Some even contemplate about increasing risk of acute myeloid leukemia. And that is a very important question in, let's say, a 30-year-old. So we tend to use interferon, which I do. But after interferon, if that doesn't work or causes side effects, should I really implement the hydroxyurea to push for hydroxyurea to satisfy definitions of a use of JAK inhibitors, or should I just go to JAK inhibitor after interferon? These are open questions and examples of clinical scenarios that are not easy to answer by the definitions. But the other aspect is to fully, and I touch upon that, to fully understand what is needed for patients to fully benefit from one or the other therapy. And that paper that was published in January 2013 in New England Journal of Medicine that proved to us that the very good control of hematocrit is really the goal. That paper and significance of it, one cannot underestimate. My goal in my therapy is to make sure that the target is always achieved, that once I introduce cytoreductive therapy, the hematocrit is all the time below 45%, and I do not need a phlebotomy to accomplish that goal. That was further substantiated by a recent presentation at the European Hematology Association meeting in Denmark earlier this year in June, where from Spanish registry, people with polycythemia vera that were prospectively followed, retrospective analysis, but the common practice in Spain was analyzed, and the patients with polycythemia vera that were on cytoreductive therapy and still required phlebotomy really did not do as well as patients that had a full benefit of cytoreductive therapy with complete elimination of phlebotomy. So this is fine-tuning of what we would say assessment of a benefit, but it's obviously clinically relevant. This is what matters for the patient's life.
Well, excellent. Well, it's a great summary, and it really was a wonderful talk today. Now, Stephen, shifting gears slightly, patients with essential thrombocythemia, they clearly can be heterogeneous. At the moment, there's not a formal indication for JAK inhibitors in ET, but it's both an area of investigation, and there clearly are patients who've received it off-label as well. Why don't you highlight for us some key takeaway points for our colleagues in the community? Where might I even be considering JAK inhibitors in ET, or where is it really being studied?
Right. So thanks, Ruben. So I think there's a couple of sort of main points to emphasize. I think with ET, the first question I think we should ask is, what are the treatment goals? Is it to control the platelet counts? Is it to alleviate symptoms, reduce risk of thrombosis, ideally prevent the likelihood of transformation to myelofibrosis or to secondary AML? All of those, optimally would be goals, but what is the primary goal? And for each patient, that may be different, or some combination. The second question, I think, is, considering that there is so far relatively limited data for JAK inhibitors in ET, maybe a way to frame this is, well, how effective or what are the characteristics of the existing treatment options for ET? And to shortly summarize that, of course, hydroxyurea is commonly used for ET. And generally, though there's certainly some debate, considered first-line option. And the experience in literature is that the majority of patients do well with hydroxyurea. The other options include anagrelide, interferon. I think we all know of the PT1 study that compared hydroxyurea versus anagrelide, and hydroxyurea was considered superior, and that is one of the main reasons why it's generally considered the first-line option. But certainly anagrelide has activity and is considered an acceptable second-line therapy at the very least. At the same time, patients have side effects with anagrelide, cardiovascular symptoms, and again, it might be at least somewhat inferior to hydroxyurea. Interferon certainly can be effective. Similar to in PV, not only can induce hematologic remissions, but even molecular responses. And while the pegylated forms are better tolerated than the shorter acting forms, there still, though, remains toxicity. From a practical standpoint, also, access to pegylated interferon is not always possible, depending on the patient's insurance coverage. Another option that I think is in some ways being sort of seeing a little bit of a resurgence is busulfan. I think certainly there's a concern about risk of leukemogenicity, but some of the smaller studies that have been published suggesting that perhaps is not at least as big of a concern as perhaps was previously thought, and it actually can be quite effective at controlling the counts, and in some patients molecular responses as well. To be conservative, I think most, if they're going to use busulfan, would still reserve it though for elderly patients. So there are certainly a number of different treatment options out there available for patients with ET, but they all have limitations or potential side effects that could cause one to consider the possibility of other therapies, and that's where potentially the role for JAK inhibitors could come in. And as far as the existing data, I guess the best data we have at this point is the phase 2 study with ruxolitinib in ET. relatively small number of patients, but I think that the take-home points here that the drug clearly has activity against the platelet counts. It does decrease in a way that's in some ways similar to what has been observed in myelofibrosis. We see the other counts decrease as well, and the dose may need to be titrated to mitigate anemia or other cytopenias. But again, I think it's clear from that relatively small study that this drug has activity in ET. It will reduce the platelet counts. Beyond that, based on the existing data, I think at this point it's a little bit unclear whether it's going to do more in terms of normalize the bone marrow changes, induce molecular responses, reduce risk of thrombosis, et cetera. But again, I think it's pretty clear, albeit from a relatively small study, that the drug has activity. As far as the niche of patients that might be appropriate for this, if you go back to, again, if you assume that hydroxyurea is the first line therapy and ask, well, what percentage of patients with ET have problems with hydroxyurea and therefore should be candidates for alternative therapies? If you go by strict definitions, for example, the ELN criteria of hydroxyurea intolerance or resistance, by those criteria, up to 20% of patients would be considered refractory or intolerant of hydroxyurea. So it's not the majority of patients, but there's a significant proportion for whom other therapies should be considered. And then again, you would have to think about, is the next best option anagrelide or interferon, or perhaps off-label use of ruxolitinib? And again, based on the current data, we don't have there's no real evidence to guide us there, but again, I think ruxolitinib is an option that could be considered. One other point I would raise is there has been a little bit of investigation of other drugs in this class of JAK inhibitors, and for instance, with fedratinib and with momelotinib, both were explored in small studies, and both of those studies were discontinued because of lack of efficacy after an interim analysis. So at this point, really the only viable option in terms of JAK inhibitors, and it would be in the off-label setting currently, is ruxolitinib for ET. As far as other investigational options, one that I would mention briefly is imetelstat, telomerase inhibitor, which was explored in a study for ET, and again clearly had activity, but because the drug is pretty myelosuppressive and has other toxicities, I think strategically the further development really is focused on myelofibrosis. So that also is not an option, at least at this time. So again, I think that there is evidence that JAK inhibitors, specifically ruxolitinib, have activity in ET. Certainly we need further investigation to validate what's been observed in the small phase 2 study, but there are several options for the treatment of ET, and this is one I think is certainly can be considered in specific scenarios.
Well, excellent summary. Perhaps shifting gear finally, I'll highlight some points that I try to raise in my talk today, really around cytopenias and JAK inhibitors in myelofibrosis. First, as I really think about cytopenias in this group of patients, I'm really thinking primarily of anemia and thrombocytopenia, and that leukopenia, neutropenia, those sort of difficulties that we really experience with MDS, AML, are uncommon in MF. They can occur, but typically in the setting of either progression to AML or marked myelosuppression from therapy, but primarily anemia and thrombocytopenia. I really view them as well as being fairly multifactorial sorts of processes. The blood counts can be low because of splenomegaly and splenic sequestration. The marrow can lead to inadequate production of these cells because of the clone, because of the fibrotic process, and clearly there can be an impact on therapy. JAK inhibition, almost predictably, has an impact on erythropoiesis and the creation of platelets. It functionally is a signaling part of that, so I almost view it as an on-target expected effect as opposed to just truly a toxicity. It really has been predictable from the beginning, and issues of dose and the amount of inhibition of JAK2 has been part, I think, as we titrate against that difficulty. Indeed, in the phase 1-2 study that Serge and I and others participated in, thrombocytopenia was the dose-limiting toxicity for ruxolitinib. So over time, I'd say we've learned several things that I try to highlight today. One, we have historically some other therapies that can have activity in this space, but really their impact has been fairly modest for these patients. The erythropoietin stimulating agents, the immunomodulatory drugs. Indeed, there was even a phase 3 study with the immunomodulatory drug pomalidomide that was negative in a placebo randomized phase 3 study. So there's other things we could try, but they really haven't been great. We know JAK inhibitors can be very powerful drugs for improving splenomegaly, symptoms, and even impacting survival. Yet I think for many clinicians, the issue of either drug-emergent cytopenias or difficulty improving cytopenias which are pre-existing remains an area of frustration. My patient needs transfusions, they're receiving therapy, and they're still needing transfusions. Over time, I'd say we've learned a few things. One, with ruxolitinib itself, I think we have learned in terms of dose modification and even in terms of our dose strategy to decrease the impact of drug-emergent cytopenias. I think that has clearly decreased. I tend to start most of my patients at 10 milligrams twice a day and then increase based on response and based on if there's cytopenias. There have been recent studies done looking at patients with platelets of either 50 or 75,000 to start, and they started them at low dose with 5 twice a day, but in many patients they were able to increase that dose over time to 10 or 15 twice a day as the body kind of, I'd say, would accommodate the impact of the JAK inhibition on both the red cell count and the platelet count.
This is very interesting aspect to learn how to use the medication, right?
Mm-hmm.
It's not that you use the same dose or the identical dose in everybody. There is a different starting dose. There's a different way of modifying the dose during the therapy based on what actually happens to the patient. And that experience, in fact, lead us to identifying new possibilities for use of JAK inhibitors. And you alluded to this by asking me where else would we using it in polycythemia vera.
Sure.
There are exceptions and cases where you would use it perhaps earlier on than the second line. And I think the time has come, in fact, to broaden the scope of possibilities to develop the drug in a different way by challenging already accepted standard therapies. And in ET, that would be the case, for example, where one would perhaps envision studies where one can compare JAK inhibitor, ruxolitinib in this case, with either anagalide or hydroxyurea and see whether they are better, rather than just wait for the patients that are refractory to anything, or going forward to prevent things from happening like we know it's happening in myelofibrosis. We are here dealing with anemia that happen on therapy in patients that have advanced features, but why not ask a question which is being asked, shall we prevent things from happening and treat patients that are low risk without any problems to prevent things from happening, and really not aiming for cure, right? It's a very hard bar, but to make it as chronic as possible and make people enjoy life without even any signs or symptoms of disease if it's possible. So knowing first how to manage, realizing the full potential of the medications, broadening the scope to not just unmet needs, but even challenging the standard therapies and preventing things from happening.
No, I would agree entirely. I think as we continue to have more individualization around our myelofibrosis therapy, and I, as I'm sure all of you will see, young patients earlier with myelofibrosis, the era of watch and wait, where we're going to watch until you get sick, is one that we're all uncomfortable with. And there's the ongoing studies, looking at ruxolitinib in patients with higher risk molecular features, again, to see can we avoid that further progression. But other points I would make in terms of the cytopenia piece. So one, I think in terms of drug-emergent cytopenias, we could probably decrease that by our strategies in terms of how we use ruxolitinib. Other areas that are in development include ruxolitinib combination studies. Our group participated in a study along with Mount Sinai looking at ruxolitinib with danazol. It was not overwhelmingly active, but a little active, and we do use it off-label as a combination in a subset of patients. Other combinations I wouldn't say are quite ready for prime time, but certainly are under investigation. Indeed, it has been challenging to try to raise counts in individuals with myelofibrosis. I would highlight that there are drugs in phase 3 studies, pacritinib, currently on a clinical hold, but data from 2 phase 3 studies are being analyzed closely, trying to estimate the benefit of this therapy that were in trials that allowed patients with marked thrombocytopenia. There have been benefits seen. There have been some concerns regarding mortality on the study, so we still need to wait for those data to mature to see if there's a role. Momelotinib is currently in phase 3 studies, specifically with improvement of anemia as an important endpoint. Those benefits in anemia were seen in early studies, and that really needs to be confirmed as well as quantified. Also, the question is always raised as well, does one lose any benefit in terms of splenomegaly or symptoms as a trade-off if we see more activity in cytopenias? So I think the phase 3 data will be important in that regard. Cytopenia improvement still remains an important area of endpoint in investigational therapies. The anti-fibrosing drug PRM-151, that is an area of great interest for imetelstat that is being tested, as well as other agents that are being tested. It really is a dynamic area. Perhaps one final thought as you see JAK inhibitors moving in the future, Serge?
Because the JAK inhibitor now is approved therapy in polycythemia vera for a second line, and as we know, initial results are very encouraging. That indeed helps majority of the people to normalize the blood cell count and the spleen and the symptoms. And indeed, the second study that perhaps is not widely known, called Response 2, that is a second randomized study that tested ruxolitinib in the second line setting in PV, were presented a few months ago at the European Hematology Association meeting, confirmed those benefits even in patients without the big spleen. So there is very robust evidence of its activity. The question is, should we really use it in frontline, where I would expect perhaps to have a study in the future comparing ruxolitinib to hydroxyurea to see whether with earlier intervention with target agents for biological abnormality that patients have would be better than the chemotherapy that we use. That is probably the next step in drug development for polycythemia vera, and in ET there are many more opportunities.
Steve, a final brief thought.
Yeah, so I think ET is in some ways sort of one step behind PV. We need to first validate that ruxolitinib has activity in ET or other JAK inhibitors perhaps, and then once that's firmly established, the where it should fall in the order of choice of therapies can be considered. And again, similar to PV, there continues to be debate, whether it should, regardless of the JAK inhibitors, whether it should be hydroxyurea or interferon or whatnot. So it's a moving target, but I think it's definitely an open question as to where these drugs should fall in the treatment of these patients.
Well, great. And I would say that I'm just excited that increasingly we're looking at individualizing care, and that many of our historical kind of dogma in how we treat or observe these diseases are really being replaced by good studies, randomized data, and increasingly better options. So I'd like to conclude and thank my colleagues, Dr. Verstavchuk and Dr. O, for their expert perspectives here on myeloproliferative neoplasms, reporting here from the U.S. focus on MPN and myelodysplastic syndromes. Thank you.